We will be presenting about visual standards in the Air Force and Navy. Over to sir.
Hello, a very good morning to everybody. Greetings from Jalandhar. At the very outset, like Vijay mentioned, that I will be covering Air Force and Navy, but frankly, most of it has already been covered by him. And whatever was left has been covered by Sandeep. So I'll be gently just repeating what they have said. Of course, the pictures are new. You can enjoy the pictures. Okay, now starting with the Navy first. Visual acuity. Like in any other field of TIL, visual acuity by far is the most important criteria. Normally for this, we use the Snell's chart at a distance of 6 meters. And like we all are aware, the illumination should be minimum 10-foot candles. Obviously, each eye will be tested separately. Near vision is usually not tested in our examination. Color perception. The Ishara chart is used for screening. It should be done. The most important thing about using an Ishara chart is that it should be done in very good light, preferably outside in daylight. If that is not possible, which is usually the case, then it should be done under good illumination, preferably via tube light. If Ishara charts are not available, then we can use the Tokyo Medical College book. Martin lantern. Martin lantern test is basically the gold standard for differentiating between CP1 and CP2. Now, it basically consists of a box which has got apertures of different sizes, 0.3 mm and 1 mm. And then at a distance of 6 meters in a totally dark room, the candidate is supposed to identify the primary colors at a distance of 6 meters. If he can identify all the colors correctly at a distance of 6 meters, then with the aperture size being 0.3, then he is considered as CP1, otherwise CP2. Hypermetropia should be done under full cycloplegic refraction. Fundus examination should be done under full mydriasis. Now the standards, as far as the officers are concerned in the Navy. The pilots obviously require the best possible vision, so they should be minimum 6x6 in the better eye and 6x9 in the worse eye, and it should be correctable to 6x6. CP1 is the basic requirement. As far as the executive cadre is concerned, they are allowed a little bit of refractive error, but it should be correctable to 6x6 in both eyes. Again, the requirement is of CP1. The technical group, the refractive error allowed is more, and they are allowed to be CP2. As far as the education group is concerned and the logistic group is concerned, they are given the maximum leverage. Vision up to 6x60 uncorrected, improving to 6x6 is a basic requirement, and they are allowed to be CP2. Near vision, usually again not tested. In case a patient has, a candidate has a near vision issue, then best possible correction is given to him. As far as the muscle balance is concerned, well, for the limit for heterophoria for distance, it should be measured at 6 meters and tested by the Maddox rod. For heterophoria for near, again tested by the Maddox rod at a distance of 30 centimeters. Ocular movements obviously should be full and free. The visual acuity is tested by the confrontation method. Now, like I mentioned earlier, for color vision, we use the MLT. Laser therapy for correction for myopia, refractive errors, is not allowed. Night vision is usually not tested, and it is only tested when there is a suspicion of congenital night blindness. Other cause of rejection can be any crossing inflammation of the eyelids or the adnexa, trachoma, xerothalia, and pterygium. Of course, media opacities involving the cornea and the lens are a cause for rejection, especially if it involves the visual axis. Manifest squint is an absolute rejection. Ptosis, severe ptosis. Now, coming to the sailors and Agniveers. First, the entry for SSR. For SSR entry, they allowed 6x12 vision, improving to 6x6. Color vision, CP2 is allowed. For the MR entry, the refractive error allowed is more, and they are allowed to be CP2 too. wearing of glasses is generally not permitted for direct entry cases. However, once they are allotted their particular branch, then they are allowed to wear glasses up to the limit of refraction allowed. Contact lenses not permitted. Laser therapy, that is for correction of refractive errors, is not acceptable in any condition. So remember, any abnormality of the eye or the visual system, be it congenital, traumatic, or pathological, can be a cause of rejection even though the visual function is well within standard limits. And that decision is up to the examining ophthalmologist. Now, the naval aircrew. Naval aircrew obviously require the best possible vision, so it should be minimum 6x6 in the better eye and 6x9 improving to 6x6 in the worse eye. Color vision CP1. Again, the fundus should be absolutely healthy. Manifest squint, ptosis interfering with the visual function, chronic uveitis are a cause for rejection. Air traffic controllers. Air traffic controllers, they are allowed to wear glasses up to better eye being vision of 6x6 uncorrected and the worse eye 6x9 correctable to 6x6. Submarine personnel, visual acuity must conform to the visual standards of S1A1. That is, it should be 6x6 in the better eye and 6x9 in the worse eye, improving to 6x6. And they should be CP1. Now, as far as LASIK or any equivalent refractive surgery is concerned, first and foremost, a certificate must be obtained from the center that LASIK has been done. The age should be minimum 20 years at the time of surgery. Minimum 12 months should have elapsed between the surgery and his coming for examination. The axial length by IOL master, which is the gold standard for us, should be equal to or less than 26 mm. The retina should be healthy, and procedures like radial keratotomy or any similar kind of a refractive surgery makes a candidate permanently unfit. Now coming to the Air Force. Obviously, the visual standards in Air Force, the requirements are far more stringent because they not only require good visual acuity, but they also require good depth perception and contrast sensitivity. Now coming to NDA, either in Kharakvasla or in the Air Force Academy. They allowed refractive error, that is up to 6x6. Excuse me, I'll be covering 2, so I need one more time. So the vision requirements are 6x6 in the better eye and 6x9 in the worse eye, which should be correctable to 6x6. Color vision should be CP1. Now coming to the air crew, other than the flying group, their refractive error they allowed is more. They allowed up to 6x24 in the better eye, 636 in the other eye, which should be correctable to 6x6 and 6x9. CP1 is again the basic requirement. As far as the Adam group is concerned, they are allowed far more refractive error, which should be, however, it should be correctable to 6x6. Again, the color vision required is CP2. Finally, the maximum amount of leverage which is given is to the metrological group, in which they are allowed to have a refractive error of hypermetropia up to 3.5 and myopia up to minus 3.5 with astigmatism. Color vision should be CP2. The logistics and the education branch, again, the requirements, the permission is the same as that of the previous category. The dental and the medical people, they are allowed the maximum amount of leverage with a refractive error of up to minus 5.5 being permitted. However, the vision should be, with correction, should be 6x6. Color vision should be minimum CP2. Other causes of rejection can be squint, manifest squint, ptosis. Ptosis, which is moderate to severe. Heterocorbia iridis, the candidate is unfit. sphincter can be considered fit if the difference in the size of the two pupils is less than 1 mm. If the candidate has been operated for cataract in pseudophakic, then he's absolutely unfit. Entropion and ectropion, candidate is unfit. All cases of progressive pterygium, again unfit. Nystagmus, all cases of nystagmus except physiological nystagmus, unfit. Uveitis, especially if there is evidence of any permanent damage, unfit. Corneal scars or media opacities, unfit. Similar with lenticular opacities. Optic nerve drusen, unfit. Now, as far as the corneal scars and the lenticular scars are concerned, opacities are concerned, some amount of leverage can be given to them if they do not involve the visual axis. They're in the far periphery, they're non-vascularized, chances of progression are not there, then you can consider making them fit. Otherwise, they're definitely unfit. CD ratio, a high cup disc ratio, you have to look at him with suspicion, especially if the ratio, there's an asymmetry of more than 0.2 between the two eyes. Of course, if there's a retinal nerve fiber layer involvement or there's a visual field defect, then the candidate is unfit. Night blindness. Now, in Army, Navy, and Air Force, all three services, the candidate at the time of recruitment or commissioning is supposed to give us a certificate that he or his family does not suffer from any congenital night blindness. This is taken across the board. Retinal lesions in the far periphery, non-progressive, he can be considered to be fit. However, if it involves the central fundus, then he's unfit. Similarly for lattice. Keratoconus, of course, any case of keratoconus will be considered unfit. I've gone through Navy and Air Force. As you can make out, the Navy and Air Force criteria is far more stringent than the Army. But then that is for obvious reasons, because the work is far more technical, involves very expensive machines. And in some cases, like in Air Force and all, contrast sensitivity and depth perception also play a very important role. I hope I could actually educate a few of you about what are the requirements at our level. Thank you.
Thank you, sir. Thank you for a very elaborate discussion on visual standards in Navy and Air Force. Next.